Welcome to Two Hypnotherapists Talking with me, Denise Billen-Mejia, in Delaware, USA.
And me, Martin Furber, in Preston, UK.
This weekly podcast is for anyone and everyone who'd like to know more about the fascinating subject of hypnosis and the benefits it offers.
I'm a clinical hypnotherapist and psychotherapist.
I'm a retired medical doctor turned consulting hypnotist.
We are Two Hypnotherapists Talking.
So let's get on with the episode.
Hi there, welcome to another edition of Two Hypnotherapists Talking with myself, Martin Furber, and my good friend and colleague, Denise Billen-Mejia.
And that's me. Hi, everybody. And today we're introducing Dr. Sue Peacock in the UK, who is a health psychologist. And she's going to explain exactly what that is for the Americans, because we don't call people that, and also talk about her special interest, which is pain and anxiety. So thank you, Sue. It's so nice of you to join us today.
Thank you very much for asking me. It's an honour. Thank you.
So can you tell us a little bit about yourself? Yeah. Where are you in the UK? Are you south or north? Or?
I'm sort of, well, I have two clinics. Well, I'm online really at most of the time at the minute, but pre-COVID, I had a clinic in Milton Keynes and a clinic in Bedford. So I guess Bedford is probably about 50 miles north of London, I guess, and Milton Keynes is a wee bit further. Milton Keynes is probably best known as being one of the cities between Cambridge and Oxford. It's kind of midway, so that's where I am. Okay. I've been a psychologist for 25 years now. I worked in the NHS for over 20 years, and about 5 years ago I went into private practice, which is fabulous. Lots of freedom, and I can see who I like and choose how I treat people, so it's fabulous. Yeah,
that's great. So what differentiates a health psychologist from what we in the States will call a clinical psychologist?
Yeah, well, in the UK there's lots of different branches of psychology. Health psychology is a relatively new discipline in terms of speciality, I guess. I tend to specialize in physical health, so a lot of the patients I will see will be chronic pain patients, people with cancer, or those who are living beyond cancer. I see a lot of respiratory patients. Anybody who's got a long-term health condition is really the people that I see. I also see quite a lot of people with insomnia, and then sometimes, the insomnia is actually secondary to the health condition that they have,
or perhaps causing it, because sleep deficits can cause so many problems.
Absolutely, yeah. So that's what I tend to do.
How did you become interested in hypnosis?
Yeah, hypnosis has always been one of those strange things that kind of fascinated me, really. Having seen it on TV like most people, before you even delve into it, I really first got interested was I was working in a pain clinic in a sort of a local general kind of hospital, and the techniques that were taught, like CBT, which is a good therapy for some, but it's not right for everybody. And that was kind of back in the day before acceptance and commitment therapy and all of these other things, and mindfulness, all of that have come out. So it was about trying to do the best for my patients, really, and trying to find something that worked for them, that was going to make their lives a little bit better, whether we could get rid of the pain or whether we could just turn it down so it was manageable, so they could get on with their lives, even to the extent of going out and having a cup of tea with friends and not being sort of socially isolated, or some of them were able to do voluntary work or go back to some kind of paid work, or just get their lives back, really.
And of course, being isolated makes pain worse.
Absolutely.
You've got nothing to distract you from the pain.
No, it's one of the reasons why we set up a support group. Because what we used to find was we used to run a pain management program, which back in the day was very much CBT. Now is more sort of acceptance commitments, but back then it was CBT.
That's actually, if I could just stop you there, that's not a term I'm familiar with. It's probably called something else over here. Could you just briefly, a little segue, talk about that for a second?
So cognitive behaviour therapy is basically it's about changing the way we see things.
Right. Well, that's a term very much used in the States, but the other one, the acceptance
and commitment theory, that's for basically what they call a third wave CBT. So it's kind of building on CBT, but it's more about acceptance and looks at the values that you hold and how you can use those to build a meaningful life despite pain.
Oh, okay.
Yeah, so what we used to find was after about 5 years, people would come back, not because their pain was any better or any worse, they just wanted to validate their pain, really. So we sort of set up this support group. It's still going about 19 years later.
Good.
Yeah, it's quite good. So what we found with that wasn't really a medically psychology thing. Okay, I'll do the odd talk and that, but more did we get speakers in who were into gardening and quizzes and sort of social things, so people could get their lives back and have friends, but it was like friends who understood pain.
Exactly. I think that's
at the last minute, it wasn't going to be the end of the world, they'd just phone the next day to see how they were, but they wouldn't stop calling like friends with pain without pain used to do. So that was quite good and got people out, and at least once a month they didn't think about their pain. So we sort of just laugh and joke and have fun.
So did you find that people readily adapted to a supportive atmosphere of group therapy as opposed to, my pain's worse than your pain type of thing? Or...
Yeah, it's interesting because when they used to first start on the pain management program, we used to have a kind of a rule that they weren't going to talk about their pain. They could come and talk to me or my colleagues, but they couldn't talk in the group about their pain because, they do have those pain competitions, don't they? I've taken medication, you've had that, da 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 da. So because they'd all been on the pain management program first, there was kind of this unsaid rule that we didn't really talk about our pain in the support group. So it kind of transferred that if I was there and they wanted to talk about their pain, they'd come and talk to me, but they wouldn't sort of take call and tell everybody about their pain. So that worked quite well. Yeah.
So that the whole run of the meeting would be a big distraction from pain then, in effect.
Yes. Yeah.
And that so once a month meeting?
Yeah, once a month. And then when they got a little bit braver, some of them who liked arts and crafts and that kind of thing set up their own little group. So
good.
Yeah, it's good. It's really good that they kind of felt that they had the confidence to do it. So they've got once a fortnight, there's the craft group, and then the other fortnight is the general support group. So there's at least two things, and lots of them have got little groups within the support group, if you know what I mean. So they'll meet for coffee and go to houses and go for walks, and some of them go to disability swimming sessions together and all that kind of stuff.
I would imagine that allows them, because they know that everybody understands chronic pain and how it can disrupt your life. If you call and say, I can't make it this week, you don't get the sort of the eye roll from, oh, you again in your pain.
Yeah, absolutely.
Because it does, it's exhausting. That in itself is exhausting.
Absolutely. And trying to justify it all the time and then feeling really bad. And then you start saying no because you don't go out because you don't want to let people down. So having this group of people who understand is really helpful. Yeah.
So where did you train first? How did you first, since this is two hypnotherapists talking, we're going to go on about the hypnosis, but please, if you want to talk about something else, go ahead. But my real question is, where did you take your first, when did you first, did you read in general first and then decide that you wanted to look at a particular author, or?
No, what I first off did was I just looked, I think I just did a Google search, to be honest, about hypnotherapy and training. And then I saw this one that was a sort of a slightly shortened version for healthcare professionals. So it was about 10 weekends, I think, 12 weekends, something like that, once a month, which I've since learned that isn't that short at all. Comparison to others. So I did that really, and then you had this sort of option of, once you kind of got your diploma, you had this option of doing an advanced diploma, which was more kind of not really research. Well, it was more sort of looking at the ethics of it all and the thing. So that was quite interesting. And then, as I said, about 5 years ago, I did a far more practical one, which for me gave me the confidence to use it much more, and just give it a go and see what happened.
In a typical, not that there's that many typical patients, but somebody who's been sent to you or somehow wound up at your door now that you're no longer within the NHS, but presumably somebody said, I know this psychologist, she'll probably be able to help you with your pain. What would be the first thing you would offer them? Obviously, you have an intake, which is probably longer than the 20 minutes that Martin and I do to make sure that it's not too...
I guess my first session is probably, well, they're all roughly an hour. I guess the first session, like you say, is the intake, finding out about the pain, what's it like, how long they've had it, what medications they're on, who else are they seeing, all that kind of stuff. What's the biggest impact on their life? What areas of life is it affecting? And then, my last question tends to be:
excuse me, is there a lot of secondary agenda stuff?
I would say no. I think that's, thinking about the time in the pain clinic, there's probably only about 2 people that we've ever thought that about. And it was quite funny because the consultant that I used to work with, she was an anaesthetist, and yeah, she's retired now, bless her, but she was great. And we had this lady outside our room once, and pain clinics, well, all NHS clinics run late, don't we? And we was notoriously always running late in our clinics because we spent time talking to people and listening. And everyone who kind of was a regular kind of knew that, so it was fine. They didn't mind too much. But there was this one lady who was a new lady once, and she was getting really upset, and the nurse kept coming in and said, "You've got to hurry up, you've got to see this lady, she's in tears, she's in tears." So we kind of juggled things and got her in sooner. And she seemed reasonably genuine, like, as best you can tell. And my colleague thought the same. And then as soon as we had finished, we looked out the window and saw her literally sprinting up the hill, running for a bus.
So that wouldn't be what I would refer to as secondary agenda. Then that would be sort of fraud. And on the other hand, maybe your session was so fabulous, she felt so much better. Yeah, I was thinking more the people, the agendas that people don't realize they have. They don't realize that they gain a lot of other sympathy. I mean, it runs out, but there is.
Yeah. I think
it stops the kids moving to Australia because mum's sick, that kind of stuff.
Yeah, there's a few of those, but to be fair, I don't know that I've seen many of them. I think because of the nature, particularly of pain clinics in the UK, because it takes so absolutely ages to even get there, I think all that's kind of gone, and all the sympathy's been left behind years ago. So I don't very often see, even in my practice now, but I guess that's because of the people that refer to me. I don't see people who have had pain for like a year or so very often. It's normally people who have had pain for 7, 8, 9, 10, 20 years.
Now, do you feel that that's a failing of the system? Do you think it would be better if we could interrupt that cycle a little earlier?
Absolutely, yes. Which is one of the good things about what's starting to develop over here, is they are having pain services in primary care. That's a good thing if they're run properly and multidisciplinary. I think that would be good. And I think that's starting to happen now. So I think that is one positive thing that is changing.
To be in a pain clinic, do you have to know the origin of the pain?
No, not necessarily. I think I think it's one of those things, isn't it? Pain is so personal. You could be referred pain, couldn't it? It could be because you've got pain in your back doesn't necessarily mean it's coming from your back. It could be or something, couldn't it? So we didn't necessarily always have to have a set diagnosis as such. And even now, I see people who just tell me they've got pain, so we don't have like a set diagnosis of, I don't know, arthritis or whatever. It's just pain. And even those ones who come to me who do the doctor shopping thing, trying to find somebody who, they keep going around, don't they, till they hope to find something that's going to, have this magic cure for them. You know, even they'll say, oh, I've got this diagnosis, and I say, let's just call it pain. That's fine. All I need to know is you've got chronic pain.
I like to write less. Do many of your patients, we have to call them clients here, but you as a licensed physician, a licensed doctor of psychology, you can call them patients. Do you see many who are on opioids or other pain medications as well?
Yes. Yeah.
Okay.
Yeah. Yeah. Well, obviously that works quite well in pain clinics because you have the doctors and the nurses, so that's quite a good referral system. You know, you can say, "Oh, can you go and see the doctor, the nurse? They want to reduce their medication." For now, what I tend to do is if they've been referred, quite a lot of my patients, clients are referred by pain doctors. So I've write to them and say, "Hey, we've done some hypnotherapy, we've done this, we've done that, whatever. Their pain's improved now. I think you need please could you consider reducing their medication and leave it to them because obviously they do the medication and have to be respectful of that."
When you're seeing clients, do you find it equivalent to be working online or in person, or do you find one works better than the other, or does it just depend on the client?
I think it depends on the client. It's an interesting question, isn't it, really? Because before COVID, I would never have dreamed of working online at all. And it was something I said, no, as soon as I can go back to my clinic, that's what I'm going to do. But it's interesting because I keep now and again I say to my clients, if I went back to clinic, do you prefer to see me there? And they'll say, well, we like to see you, but we prefer it like this because it's quicker. There's no parking issues, there's no time to get there.
I think anybody who's suffering with anything that's stress related, they're quite happy to see people online.
Right.
I was really surprised because
as you say, there isn't the travelling problem, the parking up, which is always stressful, and the expense.
Yeah, and then some of my chronic pain patients, not that I encourage this, turn up in their pajamas online, and so I know it's a bad day when they've turned up in their pajamas, but they haven't had to have that stress and that pain if it's a bad day of getting dressed and getting washed and whatever to come out. So
right, and therefore they may not have to miss the appointment, whereas physically they might have had to.
Yeah. So I think there's good and bad. I've definitely got much more used to it. Like I say, everyone's quite happy online at the minute. I'm kind of getting a little bit of cabin fever sitting in my back bedroom for so long, but
Did you actually close down your clinics, or do you still?
I've still got the one in Milton Keynes is still going, and I still do quite a lot. I don't actually physically go there, but I still see people there, kind of thing. My Bedford clinic, because it was a room in a house, and the house got sold, so I haven't actually got that room anymore.
Okay.
When I eventually go back, when the demand's there to go back to face, I shall be looking for somewhere else. But I'll probably have my clinic is in Milton Keynes. It's a private hospital, and they've got one in sort of Bedford way, so I'll probably hopefully get a room there.
Sue, could sorry, go on, Denise.
No. How many clients do you see in an average day? I assume it was quite a lot when you were under the NHS.
Yeah, in the NHS it was quite a lot, but to be fair, it's probably just as much now. I probably see. I try not to see more than 7 a day. Occasionally it's a few more, but not by choice. It's more of
at an hour a person plus all the paperwork.
Yeah, it's a fair bit.
That's a long day.
Yeah, I try not to work Fridays. I try and keep Fridays as my admin day, but it's my least favourite bit of the job, so I can easily be distracted from that.
What's the most interesting client you've seen, do you think?
I think, there's been so many over the years.
I mean, interesting from a clinical perspective. Everybody's an interesting person because they're all unique.
I think from an interesting point of view, as in interesting to us, I saw a young girl who was about 17, because I don't very often see young people. I usually see sort of adults. She was about 17, and I only saw her because nobody else would really. So I said, okay then. She'd basically been involved in a road traffic accident. I don't know if you know Milton Keynes, but it's notorious for roundabouts.
Roundabouts.
It's called Whiplash City because there's so many roundabouts. Ironically, you know, I've had an accident at one of the roundabouts, but anyway. But yeah, so she was a young girl. She'd had an accident. Basically, she was in the family car and she was in the back seat, and they'd come round a roundabout and a car had basically gone into them. And long story cut short, she got back pain and trauma, got post-traumatic stress type symptoms from the accident.
She was the driver?
No, she was passenger in the back. Yeah, I think it's her mum who was the driver. And yeah, she was interesting because when she came to me, she was a very kind of stereotypical pain patient, very gingerly walking about, not really moving, not really bending, kind of rigid, and had done the physio, had done the whatever. You know how they tend to have to do the rounds before they get to people.
Right.
Excuse me. So yeah, so she came to me and we had a bit of a chat, and we looked at the pain, how it's impacting her life. She was supposed to be doing her A levels, but she wasn't doing her A levels because she was off school. She was absolutely terrified to go in the car. Every time she went in the car, she screamed. And apparently her poor mum, the first appointment she came with me, she come from Luton to Milton Keynes, which is probably
That's a ways.
about 20-25 miles or something, I think. And yeah, probably a wee bit further. But anyway, she literally apparently screamed the whole way because she was so terrified about being in the car. So we kind of had the initial chat as we do, and it really emerged that her pain was almost secondary to the post-traumatic stress stuff. So we did some EMDR on her for the trauma, and that what was interesting was we did that and the pain lessened, and then we did some hypnosis and the pain went. So we had about 5-6 sessions, I guess. And yeah, and then I normally email them a couple of months afterwards, say, hey, how you doing, kind of thing. And yeah, she'd gone back to school and was studying her A levels, and what was more incredible was she was actually learning to drive. So it was great. And she got her life back on track, and for somebody so young, it was a really big thing for her. So that was interesting.
That's wonderful.
That's a great success story. Sue, just for the benefit of our listeners, because we're appealing to everybody, can we just enlighten them as to what EMDR may be?
I always have to think about this now.
No, it's fine. I always regard EMDR as a type of hypnotherapy anyway.
So it stands for eye movement desensitization and reprocessing. And basically it's a nice guidelines treatment for trauma. And I'm not sure anybody really knows how it works. It seems to be quite vague, because I do, like you say, think a lot of it is quite hypnotic, really. I think the nice thing about it is you don't have to keep reliving the trauma and keep talking about it, whereas CBT for trauma, you kind of talk about it, don't you? Whereas EMDR,
and then come back the next session and say it all over again.
Yeah. And just amplify it even more.
I was so glad that I could have for better things than that. So that's what we did, and over time we sort of did that, a little bit of graded exposure stuff as well. And yeah, it was just really nice to get this email back to tell me that she started the driving lessons.
Fantastic. Sue, can I just take you a little bit back to earlier in this conversation? Just because we're coming up to cough and spluttering season at the moment, you mentioned hypnotherapy and respiratory conditions, perhaps, I don't know, asthma, COPD, bronchiectasis, that type of thing. Can we talk about that a little bit? Because I think some of our listeners and viewers may find that really beneficial.
Yeah, I think for a lot of people, as we've kind of alluded to earlier, with long-term health conditions, a lot of it is about anxiety of the condition and fear of making it worse. And I think because when people get anxious, they hold their body quite stiffly, don't they? And it's in the kind of naturally protective kind of way. And because they're holding themselves so tight and so stiff, they probably can't even breathe properly to start with. So we do quite a lot of relaxation stuff. We do quite a lot of this. This is quite fun, but quite childish. But it's quite fun. We get you know, bubbles that you had as a kid with a little wand and washing up things. We do quite a lot of that, yeah, because we're all naturally really competitive, aren't we? So we always blow the biggest bubbles that we can. So and in relaxation, the outward breath is the longer breath. So we you know, when I used to see people in person, we would be blowing bubbles together in clinic. It's quite fun. Good job nobody came in, really, because they'd look and think she's gone mad. But that was quite good. Partly because it was relaxing, partly because for a lot of people it evoked the times of being a kid when life was fairly straightforward and quite stress-free.
And they're smiling. It just lifts that, just, you know, that smiling and laughing really does make you feel better.
Yeah, absolutely. And we always try and laugh, because like laughter is the best medicine, really, isn't it? You know, and again, you know, it makes you breathe deeper, doesn't it? So it's also another good reason for doing those kind of things. So yeah, we try and have fun in my sessions. You know,
sounds like it.
Kind of serious and suited and booted, but we do have fun.
Yeah, because I'm just thinking from attacking the problem from two angles, because with breathing difficulties. As somebody with asthma and COPD myself, I know when I first started to learn hypnotherapy, being hypnotized, just the act of the breaths following what the hypnotist is telling you is, in that moment, is helping you, because it's a breathing exercise. And then the long-term effects of it afterwards as well, of course, as you say, with stress reduction, with holding yourself better.
Brings your blood pressure down.
Yeah, absolutely.
And I think you breathe properly, don't you? When you're in hypnotherapy, you don't do that chest breathing thing like we all do, but you kind of breathe like we're supposed to. So it's much more relaxing, isn't it? And we learn to breathe better and deeper.
To breathe out more slowly.
Yes, but while we use the bubbles,
I'll start sending it. Right. For your session, please get a bottle of bubbles.
And talking of something else you mentioned earlier, Sue, and I know you've just come on here to have a chat with us, but I need to mention something now, because you mentioned long COVID, and I know you've co-authored a book on long COVID, haven't you?
Yes.
So I'm going to put a slide on it at the end.
Thank you.
No problem. What is it? Coping with long COVID.
Hang on.
Have you got a copy handy?
Where is it? I've got one somewhere.
You disappear into the imaginary wilderness behind you.
Like Tinkerbell in the woods there.
I don't know if I see it.
Hold it up a bit more.
It's good.
Yeah,
no,
coping with long COVID. Yeah,
it's
fabulous.
Put it in front of you, because it's, you're just showing it from my, yes, that's it. Yeah, excellent.
Fabulous. Yeah. I will put a slide with the actual cover of the book on at the end of the video for people.
Thank you.
As I say, I've got a copy of the book. That's why I remembered
it. Thank you for buying it.
Actually, COVID also gave us all an additional area of it. Not that it wouldn't have been useful anyway, but so many people have needlephobia. Yeah. It's another area that hypnosis can so much help.
Oh yeah, absolutely. Before long COVID, I part of my sessions in the hospital were in the cancer unit, and we used to, for you know, when people used to come in and need their chemo and whatever, and they have a little bit of a meltdown, so I'd quite often get paged. So, if you're not in clinic, can you pop out? So yeah, and you know, I did teach one of the nurses down there a little bit of hypnotherapy. Just so I wasn't there, because she was all, you know, I literally really had one day a week was contracted there, so that wasn't really.
really I mean, that would be an incredibly strong fear to have if you were having chemo for cancer, and your fear of that needle is greater than your fear of cancer. Yeah, that is a strong fear.
Yeah, absolutely. So yeah, I think, you know, with a few little, you know, hypnosis techniques and a little bit of singing and a bit of tapping and a bit of everything, and we could get the needle in. Singing was surprisingly good. Not that I'm a good singer at all.
It's breathing again.
Yeah.
Breathing.
Absolutely, breathing. Yeah. So it was quite nice to teach one of the nurses a few sort of basic techniques. So that was helpful.
Yeah.
Because like I say, she was there all the time, so she could deal with most people if I was in clinic or whatever.
So, Sue, just from a personal point of view, because you've worked in the NHS and you work privately, we all know that the NHS is the NICE website where they recommend hypnotherapy for IBS and for other things as well. But the NHS don't fund or provide hypnotherapy. Where do you see it going, and where would you personally like to see it going?
I think there's probably a few people like me when I worked in the NHS who would use it and nobody realised until I used to get my clinic letters. I like to think that they're becoming more enlightened. I think because there's more evidence base about it now, isn't there? There is some decent research, especially by that guy in America called Mark Jensen, I think he's called. He does some really quite, I think he's called that. I've got his book somewhere. Yeah, Mark Jensen. He's done some really quite good research around chronic pain, and I think there's lots of research, isn't there, about IBS, and I think if people took the time to look, there is actually, it's a bit of an epic thing, isn't it? But there is quite a lot of evidence out there. So I think you probably could make a case if you were working in the NHS already and you wanted to audition to say your pain clinic or whatever, I think probably not the pain clinic's not the best one to really, because they're always under resourced. Cancer services, so they're probably, you could make a case, I would guess, for some kind of work, cancer services perhaps.
I remember when one of my relatives was going through treatment for cancer. This is quite a while back. They had a lot of services because the wait time, you go in, you get your blood work, you have to wait around. So they would see the social worker and this person and that person, but they had aromatherapy and a lot of things. So I don't see why it wouldn't be incorporated at that level. It would be useful.
Yeah, I think it'd be really useful. I think there are some places that do that. I know that some hospices definitely do that. I know my local hospice, I don't know what it does now, but it definitely used to offer hypnotherapy and aromatherapy and all sorts of sort of alternative.
No, just not alternative, because there's no alternative to. Yes, complementary is good. Yes.
I mean, when I went to the pain clinic, we used to do reflexology and acupuncture and all things like that. Sadly, when the nurse retired, they didn't get anybody to do the reflexology again, but we always had acupuncture and things like that there. So I think well-funded services like cancer services, whether they'd agree with that they're well-funded or not, I don't know. In comparison to a pain clinic, they're well. I think they could probably make case. I like to think that in the future that more people will be kind of a bit like me and learn new techniques to offer choice to patients, clients, so they can
a lot of it is just exposure. We don't talk about it early enough in training for people to realize it. I have one client who has a seizure disorder, and so I see her physically. Almost all of my clients I see online, but her local doctor, who's an easy walk for me. So I'm seeing her over at their office, and they had a big meeting with all of the staff from clinic on their admin day about the fact that I was going to be around. I was allowed, but in the back, that sort of thing. And one of the nurse practitioner who does the reproductive services, who does places IUD. She said, "Oh, would it work for this?" And I said, "Yeah, want me to teach you?" "Oh, really?" "I could learn this." "Yes, you could learn this."
It's just such a big world of opportunity, isn't there? That needs to be filled.
Right. But first we have to get it recognized and get away from the pocket watches and the cloaks and the stuff. Yeah.
Can I just clarify, Denise? You're not talking about a hypnotic IUD there, are you? In the same way of
No, I am talking about.
I don't think that would work.
I would not recommend it.
No.
Although there are hypnotists who work in fertility on the other side.
Yeah, so do I.
But it is to deal with the fear of pain,
Yeah.
which is associated with the procedure. It's a very simple
And
procedure.
yeah, it's the
but
fear of invasion as well, I would imagine. It's a very
that
personal
too.
procedure.
Yes. Yes. So, and there are probably 1,000 other things that would be useful in that clinic setting.
Yeah. Well, good job you're there, because you can spread the word.
Yeah. Yeah. Well, we've got to get through the attorneys. There's all sorts of legal things, but I am allowed to at least see this one client there and talk to the staff, so it's okay.
It's a starting point.
Yes, it's a starting point, exactly.
And I guess
I think for me, it's just like a mission to get hypnotherapy accepted as other talking therapies are accepted, you know, or as EMDR is accepted. As you say, with EMDR, they're not exactly quite sure how it works, and the same could be said of hypnotherapy. We know it brings down stress and helps anything that's exacerbated by stress. We know it's good for dealing with, for distracting, for building, you know, new positive thinking processes. But this, I still don't think you can summarize the whole thing in a paragraph of exactly how it works. So.
No, I don't think so. I think there's so many different angles to it, isn't there? And I think probably most people respond differently depending on what they bring to your clinic.
Okay, really controversial question then, because you're both doctors and I'm not. I'm just a therapist. Okay, Dr. Denise, hypnotherapy, pseudoscience, yes or no?
Absolutely not pseudoscience. Lots of evidence that it works.
Pseudoscience, yes or no?
No, I don't think so.
No, great.
No. So, you know,
it doesn't matter what I think because I'm not a doctor.
It doesn't matter.
No, I think there's a tendency for people to make up things in order to. I mean, it's like when you talk about the theory of mind. You know, obviously it's a model. We don't have. Oh, look, this is the mind. We can't do that. But you have to explain things somehow. This is the way I'm explaining it today. It's not. It's just not that simple. We don't understand where our awareness, where our conscious, you know, it's not this little box in your brain. Remember back in the day when we thought that memories were just in little tiny bits of, you know, little box. And if you got that little box got disturbed, that memory was gone forever. It's just so much more complicated, so much more interesting that. And yet you don't need to know that to do hypnosis or to use hypnosis, because all hypnosis is self-hypnosis, for us to teach our patients or clients, depending on which side of the planet you're on, as to what you can call them. You don't have to know the science of it or worry about the research in order for them to receive the benefit. The research is fascinating. It certainly will guide new uses of hypnosis, but it's way less important than getting the word out that this is something that is an incredibly cost-effective way of dealing with fear and anxiety and pain. Yeah. And a lot of other things too, but fear, anxiety and pain, that covers most of it.
Yeah, and it's also a therapy that makes you feel really good, as opposed to what we were discussing earlier with some talking therapies where you're just revisiting the trauma time after time, week after week. This is a therapy. I think we could all agree, can't we, that when our clients, patients leave us at the end of a session, they feel better than when they arrive. They leave feeling better.
Yes. Yeah.
Yeah. Well, no, of course, we do need to. There's no 100% of anything, and it doesn't work for everyone. Anybody who wishes to be hypnotized will probably be hypnotized because it's a natural phenomenon, but it may take a session or two for them to bring their defenses down enough that they're able to fully join into the proceedings. But it makes me so furious that I didn't learn this 40 years ago when I was graduating medical school. I should have known this then. It would have been so useful in the emergency room, especially with small children. Because they're little walking hypnotized people. It would have been so easy.
Sue, getting back to pain for a minute, do you have, obviously you can't mention specific examples, but have you had the experience then of people coming off long-term painkillers, you know, the strong stuff, and hypnotherapists help them to either wean them off slowly or get them off, or however you do it?
Yeah, I think hypnotherapy, thinking about some examples kind of over the years, I think what's the challenge is the client patient believing that they can come off them. Doctors actually agreeing for them to come off them, although saying that is getting a little bit better now, because there's this big thing about getting people off opioids. They shouldn't be on, really, but anyway, that's a whole nother debate for probably. So yes, I have seen people over the years reduce off of opioid medication, and there is a few that don't take any medication and a few that haven't got any pain at all. Whether that's down to hypnosis or whether it's down to setting the seed with hypnosis, and they've just got on with their lives, and they've got so much in their lives now, it's still there, but they don't notice it. I don't know.
Has hypnotherapy been helpful with people who are perhaps having withdrawal symptoms from opioids? Not necessarily the pain coming back or the pain worsening, other symptoms of, associated with dependency.
I think a lot of it would be around the anxiety aspects of it, and the fear of coming off, the fear of withdrawal. I think quite a lot of it is about education, isn't it? When they're coming, not necessarily on my part, because I don't know huge amounts about the medication, but the doctor, hopefully, particularly pain clinic doctors, they will take time, or the nurses, to talk them through a withdrawal program. So I think my end would be more about dealing with the anxiety and stress and worry of coming off, and making sure that they feel confident in their pain coping strategies enough to be confident that they can come off the medication.
Yeah, I think that is worth. I think it's worth mentioning that, because we teach people how to do this for themselves. It's not like, go to you every 2 weeks so that I don't have pain every 2 weeks and then it wears off and then I have to go to you again. No, eventually you will learn enough of the techniques that you'll be able to do this for yourself. And it has a domino effect. You go, oh, look, I'm going to the dentist. It works there too. Oh, I'm doing
Yeah, it's incredible, isn't it? And when people realise how powerful it is, and like you say, all the different things they can use it for, it's just great. Yeah.
It's interesting to me also that it's pretty much accepted that people will use this in childbirth now, or at least nobody's surprised to hear that somebody used hypnosis, and yet they don't seem, they're absolutely stunned that you can have a dental procedure under hypnosis. I know.
What's worse?
Yeah.
Yeah, it's incredible, isn't it? I think even in the NHS they're teaching some of the sort of hypnobirthing techniques to some midwives. So I think that's quite encouraging in a way of getting hypnosis into the NHS, albeit a very structured kind of way. It's not very basis like we would see people if they come to our clinics, but I guess it's a start, isn't it? It's becoming more acceptable, so that can be a good thing.
We're going to have to leave it there for today. We're out of time, but can I just, can Denise and I both extend our warmest thanks to you, Sue, for coming on here. It's brilliant. We're helping dispel the myths about hypnosis, and we're trying to get the word out there. So thanks for joining us and being here.
And people are able to self-refer to you, or do they need to refer through? They can self-refer. Okay. So watch closely. There'll be an end card that will give you details for contacting Dr. Sue Peacock. Thank you so much, Susan.
Thank you.
Yeah, thanks, Sue. See you next week, Denise.
Okay. We hope you've enjoyed listening. Please remember, this podcast is designed to give you an insight into therapeutic hypnosis and is for educational purposes only. So remember, consult with your own healthcare professional if you think something you've heard may apply to you or a loved one.
If you found this episode useful, you can apply for free continuing professional development or CME credits using the link provided in the show notes. Feel free to contact either of us through the links in the show notes. Join us again next week.